And what does that mean to be breathing better? It means not to be breathing through our mouths. We can look at these athletes that are incredible and they are breathing through their nose. If you look at a horse that is running, these thoroughbreds that are racing, they're not breathing through their mouths. They're breathing through their noses because physiologically, we should be having this beautiful balance of not just oxygen. That's what we think of a lot with airway, but nitric oxide. And then also we want to be thinking of, okay, which manner of breathing through our nose or through our mouth is actually the most energy efficient. Because people will say, well, my Oura ring shows that my oxygen or whatever metric they're using, that it's saying that I've got 100% oxygen saturation. But what people often don't realize is they are actually having to work a lot for that. So sometimes people will start to see my heart rate variability isn't that great.
Welcome back to another episode of the Smarter Not Harder podcast, where we give you 1 cent solutions to $64,000 questions. I'm your host again today. My name is Dr. Scott Scher, and it's a pleasure to be back with all of you. So today's episode was super, super cool. It was on a subject that I know very little about at baseline. It wasn't taught in medical school, certainly not in practice since that time, but such a huge and important topic: myofascial oropharyngeal airways, all with an amazing speech language pathology expert named Karindy Ong. So let me give you a bio on Karindy. So she's a licensed speech language pathologist who graduated from the University of Houston with a Master of Arts in Communication and Sciences and Disorders in May 2015. She has extensive clinical experience in acute, post-acute inpatient, and outpatient rehabilitation in hospital settings. She specializes in experience in working with brain injury, disorders of consciousness, spinal cord injury, infant feeding issues, and oropharyngeal myofunctional disorders. She currently provides therapy to neurologically and medically complex patients from infancy through adulthood with feeding, swallowing, and orofacial myofunctional disorders with Myohacker SLP, her company, in Katy, Texas. So she's passionate about myofunctional therapy, feeding issues, the role of fascia, craniofacial therapy, collaborating with qualified team providers, and getting to the root cause of issues. And she uses lots of different modalities, understanding holistic and functional medicine applications, using an integrative approach. And she has so much experience with biofeedback, biohacking technologies and concepts, all kind of integrate into her sessions. Karindy is a super awesome lady. And she came up to me at a biohacking conference a couple of years ago, telling me about what she did and about the products that she was using, and actually asked if we could get a certain type of trachea made for her for specific indications. So this episode is really about all what's going on with the nose, the mouth, the face, the oropharynx, and how it's affecting us on a day-to-day basis. So we spoke about breathing dynamics, including nasal breathing, which enhances nitric oxide, how the mouth is designed, the evolution of the mouth over time, the palate specifically, the tongue, how it works, where it works, why it works, tongue ties, what they are, anterior, posterior. Then we spoke about the jaw and the evolution of the jaw and how it's gotten smaller and crunched over the years, secondary to different types of foods that we eat. We're supposed to be gnawing on things all the time with these teeth, and we just don't do that. So we spoke about the neck as well. Then we went into various disorders, especially related to sleep apnea or obstructive types of disorders, including something called upper airway resistance syndrome, which I had never heard about. But we talked about this in detail, what it is, how it arises, how women are more at risk for this than men. And then we spoke about various ways of fixing or optimizing this using all these different types of tools and technologies that Karindy has at her disposal. And in addition, we talked about how to optimize nasal breathing, mouth optimization, where your tongue should be in your mouth. I didn't know where your tongue should be. And we talked about the various aspects of swallowing, the initial swallowing, the anterior part, the posterior part, brainstem issues, dysphagia, and how she optimizes this using all these different types of tools, technology. And one of the cool things about this podcast was just that the integrative aspect of what Karindy does. She doesn't just think about things with the mouth. She was talking about, for example, referring people to podiatrists and then talking about the curvature of the spine and talking about constipation and how this all reflects on how the mouth is doing and the various things that we do to compensate for issues with our mouth over time. So I highly recommend you check out this episode. It was super fun to record. So much good information. If you like this episode, don't forget to like and subscribe below. Enjoy this episode with Karindy Ong. Karindy, I said it correctly, right?
Yes, you did.
All right. I'm going to try. So great to have you on the podcast. Thanks for being here.
Thank you so much for having me.
Yeah, I know we met a couple years ago, and when you came over to one of our booths at one of the conferences, I remember probably a biohacking conference, I would imagine, right? And I thought it was super cool. You were telling me things about the mouth and the jaw and the airway, and it was just, as a medical doctor, I had no idea about anything that you were telling me. And you had this really cool idea about using the trachea in a certain way for certain people. And I was like, I just need to know more about whatever it is that you do. And so I know we've kept in touch, and I know you have so many things that you're working on. You have your own podcast, which is great now, and getting out this information. So what I thought maybe we could start off with was maybe first, before we get into the evolutionary history of, which is what I want to do, of like the mouth and the jaw, like when people ask you what you do, what do you tell them? What do you do?
So that my elevator, we've got 30 seconds, is I tell people that I help them with optimizing their life, their brain function, and their health through their airway. What is an airway? Because honestly, it usually leads to this. And that is going to be breathing through our nose, swallowing, and breathing through, really, we shouldn't be breathing through our mouth, but all of those spaces. I help people with that so that it is not dysfunctional, which leads to a lot of problems.
Got it. Love it. And then the airway is kind of where I wanted to start anyway. So maybe we can define what the airway is as you think about it, and then talk about the evolution of our airway. Mm-hmm. I remember I was talking to a friend of mine named Brian McKenzie, and he was telling me about these long distance runners who never breathe through their mouth, for example. Yeah. And so that was very interesting to me. I mean, think if many of the people that are listening, they're like, wow, how could that ever be? I could never go on my treadmill or run a mile without breathing through my mouth. But this is possible depending on airway dynamics. Yes. So just with that in mind, I guess, is kind of a colored story. What is your sense of that progress or that progression or that evolution? I mean, and take this any way you'd like. We can go and I love history. I studied history in college. So I love to talk about how you think about all this.
Yes. So when we hear the term airway, I want to clarify, my background initially was working in the hospitals. I tend to think of airway as like respiratory therapy and people that are getting intubated on all of that. So I want, if you're listening and you have that background as a medical doctor, I'm sure you do, to kind of put that aside. And what I am talking about today is going to be, like I said, the nose and how that actually goes down all the way to the lungs. So we're going to follow that pathway, because while we can breathe through our mouth, that is not ideal. Right. We don't want to be breathing through our mouth. We want to have that humidification, that purification that occurs through the nasopharynx. So what you can imagine is that you breathe through your nose and it goes down, think like the back of your throat. And eventually that air is going to get to our lungs, where then we disseminate all of that oxygen and all of that occurs. But there actually is a very important process in the nose, which is that generation of nitric oxide. Mm-hmm. It's all of this, it's antimicrobial. It's very important as far as even, like I said, the humidification, but also cleaning out the air before it gets to our lungs. Because our lungs are not made to be doing that heavy duty purification work, as we found with COVID. This brought to light a lot of this information about how we really needed to be breathing better. And what does that mean to be breathing better? It means not to be breathing through our mouths. So as you said, we can look at these athletes that are incredible and they are breathing through their nose. If you look at a horse that is running, these thoroughbreds that are racing, they're not breathing through their mouths. They're breathing through their noses, because physiologically, we should be having this beautiful balance of not just oxygen, that's what we think of a lot with airway, but nitric oxide. And then also we want to be thinking of, okay, which manner of breathing through our nose or through our mouth is actually the most energy efficient. This is going to be a big part of, I think, our discussion today, because people will say, well, my Oura ring shows that my oxygen or whatever metric they're using, that it's saying that I've got 100% oxygen saturation. But what people often don't realize is they are actually having to work a lot for that. So sometimes people will start to see my heart rate variability isn't that great. I I feel tired, even though it shows that I slept a lot. And even if I got into deep sleep, which we can talk about that later, because that's affected by all of this, but they will see that even though their oxygen saturation looks good, they don't feel like they should. They don't feel like they've been renewed. So this is going to be an important part of why we want to be breathing more efficiently, and that is through our nose.
Okay.
So,
so that's the first part. The nose is kind of a big deal. And isn't there some sort of, with the turbinates, there's some sort of change in how air is actually getting through the nose and like from a dynamic perspective as a result of the turbinates, right?
Yes.
I don't know a lot about that, but yeah.
And so even, sometimes people will have issues. So, I'm actually going to jump into this a little bit. So we can have what is called like a deviated septum, where, you might expect this with somebody who has a history of boxing or something, that they were punched in the nose. And
I was punched in a soccer game when I was a kid, right? So
there you go. That case in point. And so that is something we expect. Okay, it affected, the nasal bridge, everything's been, it's a little wonky now. But what can actually happen is we can actually have that deviation occur as a result of changes in the palate. So I want people to right now visualize the nose and then visualize the mouth. So the palate, which is the top of the mouth, that is actually the floor of the nose. So what is happening to the palate is actually directly impacting the nose. It's also directly impacting the eyes, which we can talk about later. But all of this is going to impact our ability to breathe through our nose. So it's easy to say, breathe through your nose, just do it. But what if for different reasons you cannot, or it's very, very difficult? So that is typically why people see me. They maybe have tried to, or I'll say the adults see me. They've tried to do mouth taping because they saw it on, I don't know, a TikTok video, and they're like, oh, this is going to help my health. They put the mouth tape on and they feel a panic attack hitting them. And they're like, that's terrible. I hate it. Never going to do that again.
Yes.
And they don't understand why everyone is saying to do this and why it's a good idea. I will say, if that's your story, stop. We can talk about what you can do, but it's not surprising. And there might be structural and even central nervous system reasons why that is occurring. So that is going to be related to the tongue, and then even to the soft tissues as we get further back in the pharynx, or more, think of like you can see your uvula or your tonsils in the back. As we get further back there, you might have some collapsing. So
that's the soft tissues you mean, is sort of the area behind or like in the back of the throat, correct?
Yes.
Okay.
So we want to have really nice tension in the pharyngeal space. So those are going to be, like I said, those arches in the back that you can see, they should be nice and toned and taut. But if we haven't actually been elevating our tongue fully, which we can talk about this.
This is what I want to talk about. I want to talk about the tongue a lot, because this is like
absolutely.
This is a very interesting one for me.
Yes. Yeah. So what will happen a lot, so it really does start in infancy, that we should, and not just even infancy, in utero, we should actually be elevating the tongue so that the tip is touching right behind where our two front teeth are. You should have, so there's a ridge there, and there's actually what's called the incisive papilla. It is a very important central point for sensory information and for regulation. So we should have the tongue tip going up to that point, and then,
that's the baseline, like where your tongue should be resting, is what you mean, right?
Yes.
Okay.
Yes. And so if you're listening to this and you're like, what is she talking about? I want you to just think of bringing your tongue tip to your two front teeth, and then you pull it back.
Okay.
And there's just a little ridge right there. That's where it should be resting. Okay.
And so when you're not talking, when you're not eating, and when you're sleeping, this is where your tongue should be, basically.
Yes. And we'll actually even get into, so when you're sleeping, you can imagine if you're just resting your tongue there, all of a sudden you fall asleep, you no longer have muscle activation. What's going to happen? Your tongue is going to drop.
Right.
So it's actually a step further. It shouldn't just be there. We should have what we call suction. So where the tongue is actually suctioned up into the palate, and it is your saliva and that suction force that acts as glue, so that your tongue suctions there into your palate and you fall asleep, and your tongue is no longer dropping back.
Right. That's a big deal.
Space.
Pardon the interruption. This episode is brought to you by Health Optimization Medicine and Practice Association, a nonprofit organization training practitioners how to optimize health rather than treat disease. For this episode, check out our chronobiology module. This module is all about circadian rhythms, how to detect them, how to correct them, and using wearables and other types of metrics, biologic metrics like laboratory analysis, optimizing neurotransmitters, and so much more. We talk a lot about sleep in this episode, about the oropharyngeal airway, about the nose, about the mouth, about the palate. Check it out at homehoke.org and save 10% on this module or any module by using code podcast10 at checkout. Now back to the show. And this is a major issue. I would imagine a major issue for people as far as with their tongue dropping back, right, and causing their airway to be obstructed.
Yes.
And so is it common for people to keep putting their tongue in that location now, or is it not very common at all now, as far as what you can see?
So I will say now I have a population bias.
Sure.
That is, I am seeing the people who do not have that and actually
I understand how that goes.
Generally aware. However, before I transitioned to fully working in this space, I was working in the hospitals with brain injury and spinal cord injury and a lot of these neurodegenerative diseases that I would see. I'd be doing oral care and look in their mouth and see signs and symptoms of chronic, lifelong misuse of their oral space. So where they had, like at this point, I've never seen someone with Parkinson's who doesn't also have signs of clenching, bruxing, and struggling for air. Right. And that honestly is what set me on. I have to do this because we got to get the word out. Yeah.
So let's talk about the tongue a little bit more. So what is the tongue is obviously has a lot of different functions.
Yes.
And there's also something called tongue tie, which I think is also an interesting maybe segue into some of the things that you do with the tongue or talk about with the tongue. So what other things should we know about with the tongue overall?
Absolutely. So the tongue is very important for a variety of reasons. Obviously, we think about, okay, I use it to speak, I use it to swallow. Those are very important issues and reasons why we are using and moving it. But it also is a lymphatic pump. So when we are elevating the tongue, we have muscles that insert all the way. Think about the top of your palate. So in the back, that back space. So those arches that I was talking about, they are actually muscles that insert and are connected to the tongue. So when we are elevating and moving the tongue, we are pumping and moving fluid. We're moving any of that lymph that starts to collect. So think of your tonsils and adenoids. You should have that full elevation of the tongue to get that movement properly shifting through and out. But if we don't have it, that's where we get some stagnation. We start to get in, as we get older, you'll see calcifications that start to build up, and that can be the stylohyoid process.
Okay, in the hyoid process. Okay.
Yeah. So that's where you might have heard of Eagle syndrome, and patients who have this, I typically see it after patients, they start to have some pain, and it's just as they're not getting enough tongue movement that the calcifications start to set in. So that's directly there. It's also very important for proprioception. So you think of, you've probably seen athletes and they might balance, moving, their tongue is going side to side.
Michael Jordan, classic, right?
Yes, exactly. And, or cutting with scissors. People use their tongue.
When they're cutting, they do that? Other people do that when they're cutting?
Yeah. I don't know. Just
it's funny. That's cool. I didn't know that.
Yeah. It's just a huge part of our balancing system is that we use the tongue to offset if we're, vestibularly connected. We want to be balancing ourselves at midline. And so our tongue can actually help with this. So that is one aspect. And we can talk about sometimes as people lose that sense, that's where they start to clench. And so you might get some grounding through that.
Interesting.
But back to the tongue, it also then acts as this activator for the cranial bones. So I'm sure you're familiar with that we have cranial movement. And for a long time, this was kind of disparaged. And people were like, no, it's not a real thing. We now can see that it absolutely is. We have fascia that encapsulates the cranium, and it is between all of these bones. And so as we swallow, that pressure, that propulsion is sending that signal for us to either have a heightening and narrowing of the palate or a widening and expanding of it. We
What
want
changes that? What causes one or the other to happen?
Absolutely. So
Yeah.
if we are swallowing and we don't have that coordination of the tongue,
Okay.
which what it should be is sort of this bowl shape where the fluid or whatever it is that we are swallowing, that it is going to go down the center and it's controlled through this vacuum
Okay.
force of all of the so it's not just the tongue that
Yeah.
propels the fluid back. However, if we don't have, this is where a tongue tie comes into play. Let's say you have a tongue tie, which is fascia that is tighter or shorter than ideal, given the proportions of a person's structures. Then what can happen is that the tongue isn't able to elevate and start activating all of those vacuum forces. Then we have to use our cheeks. We have to use this suction, which the buccinators, they're active as we swallow. But that activation can be a very strong force that if you don't have the tongue acting as the scaffolding and support to the palate, instead of getting the support through those palatal bones, we get a bowing. So we get this suction force is so strong, it's now hitting the palate. This is going to give us that narrowing and heightening.
Got it. Makes sense. Yeah, okay. It does. Yeah. And then so you were talking about tongue tie here. So you're talking about the fascia being too short or too tight. Yes. What fascia are you discussing? Are you talking
about the frenum?
Okay.
So the frenum is the connection. Right. It inserts into the mandible, and we all have one. So people will watch a video or, I don't know, they're reading terrible things about tongue ties, and it says like you need to just cut it. Yeah. Please note that's not what should be happening. Right. When we're talking about a release, it's generally, there are some people that are doing it a little differently, but generally a laser that is gently placed on that fascia connection, and it should sort of melt away. Not really those connections that are too tight. So this shouldn't be this giant surgery. It's a gentle release of tension that we're not able to move through. And because you can do exercises and stretches and things, but fascia doesn't give like that. It's going to have a range of motion that it's the height, and that's where we might need to intercede.
Got it. Okay. And so when it comes to, let's talk about the jaw a little bit, because I know I was listening to you speak about the jaw and how the evolution of the jaw has changed so much. Mm-hmm. So how's the jaw involved in here, and how is it sort of evolved, and how are we having challenges with that? I mean, we're having challenges with everything, of course, but specifically with the jaw, how do you think about that?
So I'll start with discussion of the function of the jaw. We ideally should be chewing hard foods that stimulate, there's osteoblasts that stimulate bone growth from the time that we are infants and all the way up through adulthood. And we shouldn't stop. It should continue, that we're continually getting this input through our teeth and through, again, those cranial bones, because it's not just teeth that we're growing, it's the whole skull as we chew. And we should have, again, that swallow pattern that where the tongue is providing that scaffolding to the palate. We need that. And what you'll find is that the upper jaw, which is going to be the maxilla, or just think of like your upper teeth. And if you sort of touch back to your cheekbones, you want to be growing that. And your jaw, while it does have this genetic predisposition that it's going to follow your genes, it's also going to follow what is happening with that upper jaw. Okay. So as we get this, well, I'll go back a little bit more into the history. So we see, if you look at skulls and jaws, and the book Breath by James Nestor does a wonderful job of covering this. So I highly recommend reading that. But you'll see that really we got to the Industrial Revolution, had nice wide skulls and jaws for the most part. And then we have these processed foods, things start to shrink. As we get that shrinking, that's where we start to get more of these cavities, more of this decay that we didn't see. I mean, we saw skulls where they had all of their teeth, wisdom teeth included, and they had space for it. So we see that it truly is, I mean, within a generation, things start to shift and get smaller.
And the shrinking, what do you mean by shrinking exactly here?
So the shrinking is narrowing. So we see what happens. Like I said, we have a genetic blueprint of what our body wants to do with the jaw. It does have that to an extent, but the angle of the jaw and the way in which it's positioned is where we see this narrowing and shrinking. is that rather than it being wide and sort of a square set,
Right.
that it
Right.
becomes long
I see.
and narrow.
And this is why we have to have all of our children need braces these days, right? So
we can talk about braces.
Oh, okay. This is interesting. Okay. I'd like to talk a little bit. But the narrowing is happening because of the Industrial Revolution, changes in type of food. And then we have all these teeth in our mouth that are getting crowded and having problems. And then we're getting cavities and everything else.
Yes.
Okay. And so when it comes to, let's talk about the neck briefly now too, just to kind of go, there's probably more that we need to go into as far as anatomy goes, but I'm all yours where you want to take me there. But let's talk about the neck and the swallowing and how that piece falls into everything here too.
Absolutely. So I'll start with pain. So some people come to me because they have neck pain.
Okay.
And it is a result of that tension in the mouth. So it can be tension in the floor of the mouth or tension as a result of this disorganized swallow pattern where they have that tension in the tongue of the frenum that is pulling them. And I'll feel it as I feel their neck every time they swallow, that you feel that pulling. And so these tension patterns, they actually can insert into the hyoid and it can shift all of these, the posterior pharyngeal constrictors, all of these are relating to the tension that we start in the mouth. So it's not just the mouth. As you see, it is the neck as well. And we start to bring our head forward to posturally compensate for some of these restrictions or negative patterns that we have. And when you bring your head forward, it does open your airway space, which when we talk about that airway space, that's going to be the base of the tongue, or think of the back of the tongue to the posterior pharyngeal constrictors, which are going to be, you've got your spinal cord and then you've got muscles, tissues that go in front of it. So think the back of your throat and then the back of your tongue, we get that. That is going to be a measurement that's very important for things like cone beam scans. And that tells us where you're at. And so sometimes people will come and see me. I had one patient who's this was the case for her. And the dentist had done a cone beam and said she has the widest airway I've ever seen. She was like, I don't know why she's having these seizures and these concerns. But when you looked at the scan itself, the lordosis was completely gone. So that curvature of the neck, she had lost as a 17-year-old to compensate and open her airway.
So she compensated to open it, you mean?
Yes. Which, as you can imagine, when we do that, this shifts the pelvic floor. This shifts the diaphragm. It shifts how we are actually moving and living on a daily basis.
And this is all, and what was her compensation for? Do you recall as far as why she needed to do this?
So this is a good question.
Yeah.
Some people can function really well with, honestly, an airway that's a tiny straw. Yeah. And they're okay. Like so I will say that there is a lot of bioindividuality around this. Like they're okay. She needed a wide open airway space for her to feel her body breathe. She did end up needing more support she had central sleep apnea, which is different from obstructive sleep apnea.
Sure. But she had more of a reaction stress response that required her to think that she needed more air because she was stopping to breathe. Makes sense.
Yes. So everyone's a little different. And this is where it's very important to not just not every treatment is correct for everyone.
Totally. Yeah.
Because sometimes we have structural differences, but it can also be, like I said, a central nervous system issue in that someone goes, I need the sensation of a lot more pressure down my pharynx to feel regulated. Other people don't need that much.
Right. I think what you're really talking about here, and I think a lot of practitioners do this in their own way. It's like we see our work as sort of a window into the rest of the body, right? In the sense of the compensatory mechanisms that you're requiring or that you're talking about. Is it a chicken before the egg scenario? I think that's the question, right? And that's what you're really trying to probably discover a lot, I would imagine, as you're doing these kinds of workups.
Especially when it comes to, so I also work with babies. And when I'm working with babies, it's a very different diagnostic protocol that I'm going through versus an adult. They have a different history. And so the treatment's obviously going to be different, but often that underlying issue is very similar. of why. I just see, okay, this is what happens if we don't address it in infancy.
Right. And you see the compensatory mechanisms in somebody that's had these kinds of issues throughout their whole life when they thought they had back issues or diaphragmatic issues, but it really was because they had a hard time with their airway.
Yes, there can be. I love working with a podiatrist. I refer to her.
Nice.
And we'll reach out because we also compensate if we're not getting that full movement, range of motion through the feet. This actually does impact how we are adjusting our posture from a head and neck standpoint. So sometimes, and it's generally a little complex as far as how this is originating, but I will work with families on, we're doing exercises and stretches in the baby's mouth. But as they get into crawling, if I see that they're not actually getting that range of motion through the toes,
interesting,
that's where I'm like, we need to be activating and stimulating this and giving that compression through the joints. Because if they are not getting that joint on joint compression through ankle to knee to hip, you're going to see it starts changing. They're going to get compression somewhere.
That's so interesting.
Getting it in the jaw.
It's all kind of related to the proprioception, related to how the feet are hitting the ground. I mean, do you see that in adults as well, where you have to?
Absolutely.
It's so interesting. So so you're often giving referrals to podiatrists for people's feet along at the same time, or is that more common for babies?
So I have to be very careful. I do need to stay in my scope, but I will say, if it were me, I would consider looking at a way to stabilize your heel, or things like this. Because you'll see if the heel is turning out, then suddenly they look like they're pronating and suddenly they're clenching because they need that trigeminal input to feel grounded, because they are no longer grounding through those lower joints, and it sends that whole signal up the chain. So
interesting.
You'll see in babies, we ground, we get that signal from the mouth down. Yeah. But sometimes as we get older, we might need to treat it from the feet up.
So you said this is a trigeminal reaction?
So the trigeminal nerve is, the nerve that for the most part innervates the jaw and the muscles of mastication, but it's also very important. It has a direct relay to the brainstem, to our brain. And as it activates, it's also our nociception hotline. Like, it is really a center for feeling pain.
So trigeminal neurologist, that's true.
Yes. So what you can have happen is that people are trying to ground, trying to feel themselves, that sense of self in space, which is proprioception. And as they're trying to get that through the joint, through the jaw, it works until suddenly they get a little more inflamed because they're having all of these toxins in their environment. And suddenly that's where we get to this point where they're now in significant pain. But if they get rid of the pain, they're no longer grounded. So this can actually lead to quite a few mental health concerns.
So you're saying that we all need to get outside in the sunlight and ground every morning for the purposes of the trigeminal nerve
I will
optimization.
say it's different. It's different. So I'm talking about compression through the joints ground, not necessarily. So if you follow any of the Postural Restoration Institute kind of work, they'll talk about this. It's a little bit of a different sense, but you absolutely need the electron transfer of grounding in the sun out in the dirt as well. And truly that makes a huge difference in regards to the connective tissue. And the circadian, we can go there. But
I see where you mean. Okay. So different type of grounding, so that's a clarification there as far as, that's important for me to understand.
They're both important and they interact.
Yeah, because I know you call yourself the Myohacker for a reason. So you're the ultimate biohacker alongside of all this, and it kind of all integrates. So I wanted to, that was a great overview, Karindy. I really appreciate it because it really helps me kind of understand the framework. And I think people that are listening, like me, that that know something about something, but don't very little about this overall. I think maybe the easiest way to kind of go through kind of how you understand and how you optimize the airway would be through a condition. I think a very common one would be, let's talk about sleep apnea. So I think that's a big issue. Let's give an overview of sleep apnea for everybody. Let's think about how you would approach somebody with sleep apnea from your perspective and some of the most common things that you see overall. I mean, it's kind of funny. I was actually recording a podcast right before this, and a guy's like, well, I snore every night. I'm lean. I don't know why. I've gotten a sleep test and I'm okay. I'm like, I don't know how to answer that question, but I think in the next hour and a half, I'm going to know.
So let's actually talk specifically about his case.
Yeah, sure. Yeah.
And I will say that this is where I actually see a lot of women land, is not necessarily obstructive sleep apnea, but upper airway resistance syndrome. So what this is it is, we have these markers for obstructive sleep apnea, which I won't say they're out of date, but I think we need to do some updates to them.
Okay, they're out of date. It's okay. You
Gender,
can say it.
weight, age specific updates. So we do run across, they're normed for 40-year-old men that are within a weight range. And so if you have an athlete who is having difficulty with their sleep, but shouldn't, by all, of these indications of these markers, this is where we look and see, okay, are they actually getting what we call upper airway resistance syndrome, which is where their body, as it starts to get into those deeper stages of sleep, relaxes. And this is where they start to get that as the tissues relax, they're no longer holding their shape and the airway is no longer nice and wide and open. Things start to collapse, but not so much that it's considered an apnea, which would be a full break, a full stop in that airway flow. And so what happens is this is a pretty strong signal to the brain. The brain is more sensitive in a case of UARS than it is in obstructive sleep apnea, generally speaking. And so what happens is that obstructive sleep apnea, let's say it's the tongue that falls back in the airway. They're sleeping great until they get that occlusion that it blocks the airway for maybe 3 seconds. Then they suddenly take that gasp, that breath, or they feel like the sensation to pee because their kidneys wake them up because they're like, we got to breathe. So you might have that. That's considered an obstruction.
Sure.
In UARS, they start to get back there. They start to get this resistance. They don't get a full blockage, but they get resistance and the body alerts itself and wakes up before they ever got to that clinical diagnosis of having an issue.
Right. So they weren't necessarily hypoxic at the time.
Exactly.
Is what you mean, right?
Yes.
So what are the major causes of this overall?
So the causes, well, real quick, I want to say, so if you have UARS, this is going to be impacting your deep sleep. And I'll get to the causes in a second. But I just want to say it's very important because even though it's not as easy to diagnose in many ways as overt obstructive sleep apnea, it is still affecting your ability to drain your brain at night. Your glymphatic system kicks on when you're in those deep stages of sleep. And as you have this, you actually are getting less and less. So sometimes I'll see patients with obstructive sleep apnea who actually have better deep stages of sleep because they get there. They do have obstructions, but they get some. But UARS, these are the ones where I see the really striking
These are like the 5 minutes of deep sleep kind of people, like that no matter what they do. This is really helpful because I have a number of my own clients actually that we've been able to optimize a lot of stuff, but just cannot crunch. We cannot, get through and get increase in their deep sleep. So this could be what potentially is going on.
Yes, absolutely. So causes are going to be loose connective tissue. We're seeing this more and more, which this is, again, we go back to, we've got gut permeability. We have just connection issues throughout the body.
So wait, what? So you're talking about gut permeability causing loose connective tissue in your mouth and your throat?
So I probably shouldn't say causing, but let's say
correlated.
Yes. There we go. Because as we have this connective tissue that is not, that these junctures are open, you're going to see that we actually have shifts in muscle tone and in the energy required for the body to maintain whatever it's holding. It requires a lot more effort for the muscles and for just the connective tissue to actually be there. And so it's energy inefficient.
Got it.
We see
is it related to like an inflammatory kind of state? And because what I think about here is that if somebody has a leaky gut and that's going to cause immune system activation, that's going to cause inflammatory cascades to get out of whack. It's also going to cause a leaky blood-brain barrier, for example.
Yes.
So you see this correlated with these loose connective tissues like that kind of line and are responsible for airway movement and airway optimization overall.
Absolutely. I see so that is, you can work on muscle tone and doing these exercises and all of this, which I can talk about later. But I think it's important to understand there's this foundational, just molecular point that we need to get to for you to really see changes there. Now, sometimes, I work a lot with kids that have autism that are very, very specific in what they will and will not eat.
Of course.
We are going to work a little bit more on those exercises first before we're truly getting to changes in the molecular structure, because they're not able to tolerate some of those supplements or changes in diet and things like that. So you can go back and forth, but I'll say it is best in my clinical opinion, from what I've seen, if we can start getting that foundation of healthier tissue, healthier electron signaling, mitochondrial input, then it's so much faster. Like the brain, for one thing, it's not so tired to be able to learn these changes we need to be able to breathe easier.
I love it. Because it's really just a very similar framework that I use in clinical practice, right? The more of the framework or the foundation that you use that within the framework that you use in clinical practice. So for me, that's laboratory testing and vitamin, mineral, nutrient, and optimization using the framework that we use as, the major sponsor of this podcast, Health Optimization, Medicine, and Practice. Like that is what's going to create that foundation. If you're just trying to optimize something, like, for example, for me in a hyperbaric chamber, just like putting somebody in a chamber that hasn't done any of that work, you don't see the kinds of outcomes overall. So is that what you typically see? So if, like, I guess in an adult, for example, if you're working with them on, this upper airway resistance syndrome, and they're eating McDonald's every day, and they're drinking alcohol all the time, do the exercises still work, or is it something that's much more difficult for you to see improvement?
So it does actually help.
It's good stuff.
I do see changes. I don't recommend that for anyone. However, I meet people where they are at.
I totally understand. Yeah.
And so that actually does help. If we can just get some of that tone, that improvement in the pharyngeal space, they actually have improvements in their sleep quality. And that's even great. Like I said, the fluid, because your tongue, if you're not moving it, which, we think we're moving it, but often people are moving it in conjunction with the jaw, which has its own wear and tear and is not what we want to do, that you'll see as individuals start moving the tongue, that it actually becomes less inflamed itself and it takes up less space. I mean, so just that, and then they have better proprioceptive awareness as well, which is just, it makes a huge difference on just their overall health. And also it helps with things such as reflux, because if we're not getting that propulsion pattern, we often have issues with, we're not getting that cohesive swallow all the way down. And so we're swallowing air, and then this can cause its own set of problems. It can change the pH and everything. So all of that, like, you can have changes. And that's why I'm like, we have to know about this, because it actually can make such a difference, even if you're not doing all those other things.
That's really good to know. That's really good to know. So it's good to know that you can really start with some of these changes without having to do a lot of the other foundational stuff. Although if you do the foundational stuff, it's going to work better and you're going to see faster and probably more improvements than you would otherwise. You were mentioning the swallow there, which I think is interesting. I want to get back to that. But before I do, as I don't want to get off track, is when it comes to, you said women have a higher propensity of this particular condition where you have this upper airway resistance. Why is that the case?
So there's a lot of discussion about the why. And I think in the next couple of years, we're going to have a lot more research that talks about this. Some of it is just, you'll see men in general. Well, I'm going to talk about some things, and then there's hormones, obviously. But a lot of it is just men in general will just open, and they don't know they have a problem until they're in their 60s, because they're managing, they're just breathing wide open, versus women, I tend to see that they try for the most part to not do that as much. So we have sort of a compensation throughout the day. So by the time we get to sleep at night, there's just been a little bit of a different fatigue on the system. So that is one aspect. But then another aspect is just, I mean, and we're seeing this more and more through research, is that women don't have the same responses to that oxygen nitric oxide exchange that men do, and can be a little bit more sensitive. Not everyone. So again, this isn't going to be the case for everyone, but some nervous systems are a little bit more heightened. So we're going to see in cases of like dysautonomia, POTS, I see this a lot. And usually what I find is they're okay. Some cases are not, but maybe there was some Lyme, there was some mold, triggered a little bit more inflammation, and suddenly we've hit a wall. Like we were okay. And then when we have a toxin exposure or some type of increased stress, like having children, suddenly that glymphatic system, especially if they have a reduction in sleep quality and sleep, which I don't know a mother who hasn't. So if that hits, that glymphatic system that was suboptimal already really gets sluggish. And that can be an increased stressor to the body. Then usually what we'll see is this exacerbation of TMJ pain because they're clenching, all of that. So the short of it is we don't exactly know all the reasons, but we do see that it's there. And thankfully, more sleep medicine physicians are looking into this and actually looking for the UARS and for those symptoms that are going to be like the clenching, grinding. If you have tori, which those are going to be bone growths that you can have in the mandible or in the palate, and it's that excessive bone growth, which can come from when we clench and grind. We actually do dilate the airway a little bit and open it. So
that's one reason why people grind, is that they're actually dilating their airway open as a result.
Yes, and it moves the tongue. It also helps when you clench. You actually give yourself a little bit of space in the Palatine suture, or so down the palate. You have this bony ridge. When you clench, you actually dilate it a little bit. So sometimes people will see me after they come in because suddenly they have these terrible headaches. And I find, I ask questions, find out that they placed an upper night guard 3 months ago. So suddenly they have lost that ability to dilate the airway to get some of that compression and movement. So their signs and symptoms have actually gotten worse.
Got it. Okay. So with this upper airway resistance syndrome, do you feel like this is one of the major things that you see? I mean, obviously getting a diagnosis of sleep apnea is relatively straightforward, although, as you said, the criteria sound like they need a major update overall as far as who gets it. Is there any other major airway issues that you see overall?
Oh, yes. I mean, so I'll say, these are going to be those signs that happen, that are affecting your sleep. But what you can have is just not only your sleep, that it's actually affecting how you're functioning throughout the day. And this teeth, that's usually where people come in. Because as adults, they come in because their teeth, they're having issues. And this can be subtle. Like yesterday, I was working with a woman who she was like, I've never had issues. And then suddenly I have this radiating pain through my teeth, and just watching her function and looking at the basically wear and tear patterns of her bite, seeing that she has had a little bit of a movement with her jaw because she can't dissociate the tongue, which what that means is move the tongue separate from the jaw. So she has used her jaw for 40 years to move her tongue, and it was okay. But then this is where I ask, have you had changes? Are you starting to notice changes in hormones? Because what can happen, again, back to that connective tissue, as we get a little bit of a reduction in that signaling output, what was okay before, the ligaments get a little lax. We start to get some changes that are so subtle that now what used to be okay, she's hitting her tooth on the side because that she's lost some of that elasticity and strength. So it can be things like that. It's so pain, sudden weight gain. Saw this a lot with COVID. People, they were like, I was okay, and then I got COVID, and now like what's happening? And that can be, we really have to reel it in to get that nitric oxide exchange to help them. People come and see me a lot if they have neurological concerns, seizures, things like that, because of my background. And as we optimize the airway, we get a reduction in those types of symptoms.
Yeah. So let's talk about that. Let's talk about optimizing the airway. I mean, there's lots of different, I would imagine it changes a lot depending on the situation, right? Maybe we could stick with the sleep apnea, the upper airway resistance syndrome. I'm going to get that down at some point and understand, like, how would you approach somebody coming in? What's your framework to start working with somebody? You already talked about the teeth a little bit and other things, and I'm going to ask you questions along the way, but what's your framework? How do you kind of approach somebody?
Absolutely. So I want to see when they come in, okay, can they breathe through their nose at all? As we're talking, I'm going to see, are they getting any of those breaths? or is it going to be completely through their mouth? And that just tells me one thing. I'm also going to look at, do we have tonsils and adenoids that are enlarged that could potentially be obscuring or blocking that ability to breathe through? Because it doesn't just change your ability to breathe through your mouth if you're breathing and you have tonsils and adenoids that are enlarged. It's actually, even though it's more obvious as you look in the mouth, it is impeding the airflow through the nose. So that's going to, sometimes we're going to shift and we need to isolate that a little bit and get those to go down. But I'm also going to look at range of motion of their tongue. So when they open, so here's kind of a good rule of thumb of anterior tongue ties. Those are going to be tongue ties that are attached at the tip of the tongue. Those tend to be spotted. I say tend to. They're spotted a lot more than what's called a posterior tongue tie. And we're changing the framework of what those are called in the research now, but I'll just stick to that for now. So think of sort of the front versus the back of the tongue. What I'll do is have people open their mouth and I'll ask them to, I'll say, okay, I ask them to stick their tongue out more because I want to see, it's an indicator of health when we look at the tongue, but that you can stick your tongue out and still be tongue tied. It's not an indication of that. What's going to be more an indication for me about their function is when they open their mouth, I kind of get a measure of how wide that is. So let's say you open it and it's like your finger, you go, and it's about that wide open. And then you bring your tongue tip up to that spot that we talked about at the beginning, or I might have them at first just sort of touch their teeth. And then we go back. But so I get that. And it's pretty close for me when I do it. So then, sorry, I'm saying guys. I don't know if you're watching it, then you'll know what I'm doing. But if you're not, I'm opening my jaw and I am checking to see, is my tongue tip the same when it goes up behind my two front teeth? Is the opening of my mouth the same height?
The same,
close to it. We want it to be about 80% of that range of motion. And then what I'll have people do, and often they can't do this measurement, but I'll explain it and then show how I get people to do it. So I'll ask them to do a suction hold of their tongue, and they should be able to hold the back of their tongue up. Okay. So it's suctioned all the way in their palate while they open their mouth. And ideally it would be about the same height. It's not, but functionally, we just want to see, okay, how close are they to that? Sure. And what I'll have people do is just a click. So if you were listening, you're like, what is she talking about? What you can do is just think of a kind of a loud click. Yeah. And then I have people slow it down and then they kind of hold that click. And that's how we get that measurement. So if I see that they are they're nowhere near. So when they open their mouth really wide and then they do those clicks and that tongue tip up, that it's nowhere near the same measurement, I know I'm likely working with someone who has a tethered oral tissue. I cannot diagnose that. I'm not a surgeon, but generally speaking, that's what I know we're working with. So we're going to look and work on that tongue coordination and getting them to actually isolate movement of the tongue away from the jaw. Okay. So that's very important. And then the nasal breathing. And so really dysphagia, speech therapy, it's going to be more of that pharyngeal swallow. So the swallow in the back. Myofunctional therapists, and those can be OTs, RDHs, SLPs. We are working on that stabilization of the tongue and getting that nasal breathing and then that swallow, just the oral phase. So it's really, how can we get that? So that's what I'll work with them on, depending on the symptoms. And there are exercises we do. And a lot of it is like, we might stabilize the jaw. So I have them bite down on something, practice moving their tongue, and then other things. But it's a slow workup. And especially with adults, I have to be careful because we can increase jaw pain. So as you're listening, and if you're playing along, be mindful of that. You might have jaw pain, but it tends to be a pretty rewarding process to see people suddenly moving and breathing and sleeping better.
Yeah, this is great. So let's talk about nasal hygiene briefly for people, because as I said to you before we got started, this is interesting to me, although maybe I have other issues, it sounds like, but that'll be a different story. But we can use me as a use case too. But what are some things you recommend typically for nasal hygiene overall?
Absolutely. So it's going to be a little different for kids versus adults as far as the approach, but the end result should be the same. I
Okay.
want us to be irrigating, which is going to be really cleaning the nasopharynx and the nose with saline spray, or it's not even a spray. Like when we're actually cleaning it out, that can be, people use a neti pot, or they'll use those squeeze bottles, like a Neil Med squeeze bottle. And it's that saline going up and down. And this is where a lot of people check out because maybe they tried it.
Right.
And because of shifts in the nasal bones and how, again, if they had an injury, they're not going to find that it's actually going to wash in and out the other side, which is usually how people are told to do it.
Right.
In those cases, they might get an obstruction. It's painful. It doesn't feel good, or it's at least uncomfortable. So in those cases, I'm going to have them actually squeeze that saline rinse in and then out the same nair or the same nose or nasal pathway. So I want it to go so in and out, regardless of whether it's going up the top and back down. Just rinsing is going to actually help with getting things out and then breathing. And then I do love for people to follow up with xylitol. So X-Clear has made this really easy. Yep. You got the spray and you can just use that. At home, we have, because we do it so much, we have just a big bag of xylitol and we throw it in the rinse. And then that actually helps. So then you can do it all at once. It actually helps to keep irritants from adhering to the nasopharynx. So instead of them sitting in your nose and causing inflammation, causing problems, it's too slippery. They can't adhere. And so, and there's also a really great pediatrician here who she's doing lots of research on Marcons and other things. And she talks about that she's actually seen that xylitol can break up some of those biofilms. So I would defer to her, but
it's an antibacterial. Yep.
Okay. So, I mean, it's been pretty cool to see that. So in these cases of chronic molds and issues, especially with kiddos who are maybe not going to tolerate some of those stronger nasal sprays to break that up.
Right. It's usually a place, it's a reservoir too, where a lot of the infections kind of hang out. So having that kind of clearance, it can be really helpful in people, especially with chronic stuff. Yeah.
So what I want people to do is you clean out your nose. If you're listening and you're like, okay, I can do that as an adult, but how do I get my kid to do this?
Yeah.
This is where, so babies also need to be doing it. Okay. I want everybody breathing through their noses. So what that looks like is, when they're younger, a saline spray that has an aerosolized nozzle.
Aerosolized. Okay. Gotcha.
And it's just going to be faster. Okay. So that you want to do it fast. When I have some kids, you don't have to do a big song and dance to get them to do it. They're like, okay, whatever. But often we introduce it in the shower. So tell parents, like, I want you to take this. They play with it in the bath, get used to it, spraying their face, hearing the noise. And then parents have to model it. Kids, if they're never seeing an adult model this, they're not going to do it. Okay. So you have to model it. And then having the kids spray their noses. I mean, now my boys, it's just on their checklist. They do it at night. They do it in the morning. And it's just a great way for them to actually just, now they're breathing great.
It's part of their hygiene. I understand. Yeah. Got it. So that's typically twice a day you recommend it then? Like in the morning when you wake up?
It is. I'll be honest. Most of the time, if you can do it at night, that's going to be great because we're all busy in the morning. But if you can, it's going to help you. If you're like, I didn't get to do it in the morning, then you might find that you need to do basically it's considered a nasal decongestion exercise where we don't have to walk through it now. But it's a great one that I actually recommend people do a lot, where you breathe in and out through your nose and then you pinch it closed after you breathe out.
After you breathe out. Okay.
So actually I will walk us through. So you breathe in and then out and then in and that. And then you breathe after you've exhaled everything out. You pinch your nose. And then as long as you don't have neck pain, you're going to rock it back and forth 8 times.
Rock back
it helps bring some of that stale air out. And then this is the trick that people forget is the exhale. So then exhale. So you exhale, pinch your nose, move your head, exhale again.
Oh, so you further exhale.
Yes. And it brings this stale, nasty air out of the turbinates and sinuses. And then that about 3 rounds of that can actually bring down inflammation in the nose, which just helps. Yeah.
These are all things that I need to know. I mean, I've had a deviated septum for a long time, so it's helpful to get some of these tricks.
Absolutely.
And I'm sure there's many more, but let's go to the mouth and the teeth as well. So what are some tricks to the trade, some things you do for the mouth, some exercises that you recommend I know it probably depends on the person, but I know you have lots of crazy contraptions and things even look like trochees for people sometimes
Yes.
in their mouth too. So
I know. I've got to say, yours are such a good texture and they stick. That's why I do actually have people use the GABA. I'm like,
I love it.
The calm. So,
I love it.
you can take something that is really anything that's kind of a dissolvable solid, and it can be a food that you've taken a bite of and softened, and you just place it behind those two front teeth, and I have them hold it. So
with your tongue, you put your tongue to that. Okay. So that's what you do with the trochee. You just have them keep it there. Okay.
Yes. So what I like is that it sticks there. So having that and just that awareness is a great way to start training. Okay, that's where our tongue needs to be anchored. And that makes a huge difference in kids. It's going to help with that interior or forward growth of the face. It's also going to help with just directing that swallow. Because I see a lot of individuals who have what we call a tongue thrust swallow. And this is where, for whatever reason, it can be a tie. It can just be they had a cold as a kid and then they got used to swallowing this way. That they, instead of that tongue going up, that they actually use the mid blade or kind of the middle of their tongue, and it protrudes forward to help them swallow. Because that will give you some traction in the back. It gets the bulk of the tongue up. So it's a way to compensate. But that's where you can see an open bite. You can see it starts changing dentition. So I see this also in adults. And these can be the adults that have gone through 3 rounds of ortho and they don't know why it's not sticking. And their Invisalign guy said, go ahead and get a myofunctional therapist. This is broken. And that's where it is. So that's one thing. I also do tell people, cheek punches. This is something that I'll have people do. I'll have them sort of stabilize their jaw, because the trick is I don't want people doing this and swinging their jaw, because that's gonna hurt. And so what I'll have them do is I'll just put like my finger on their cheek. So if you're watching, you see this, but if you're not, my finger's kind of on the side of my mouth, like right at the cheek between my mouth and my ear. And then I press my tongue into it. So it's just a little bit of pressure. And doing that, this is actually a great one to help with some of that lymphatic drainage if we see tonsils and adenoids are inflamed. So just like that. And then there are other things depending on what I have, like your friend who has the snoring, tell him about the Replenish nozzle. It's a great tool that actually helps with that tone in the back. It's not a tool for everyone depending on what they have going on, but just based on what you said, it sounds like it'd be good because it actually uses some resistance to activate the back of the throat. So the
nozzle. Tell me what this thing looks like.
So it's called the Replenish nozzle.
Okay.
And it is it's like a straw tip that you have to use the tongue and tight suction in the back. And that actually helps tone. So there are other exercises that I won't do on the podcast because they sound crazy, but that it really can be as you're looking up and you're extending your tongue forward. That is also a way to increase that tone.
Yeah, I heard you talk about something called frog jumping before. What is that?
Yes. Okay, so frog jumping. So this, when I'm working with kids, as you can imagine, I'm describing these things for adults who will sit there and follow along for the most part, that it's easier to train than it is for kids. So with kids, I do a lot more of whole body feedback. They're not necessarily going to do a click with their tongue unless it's a part of a game. And I'm increasing that proprioceptive input throughout the whole body. So what I'll have them do is make that click, that as they then are and I'm jumping with them, we are jumping on the floor and doing these big hops. That's a great way to help them actually. And you can think of, again, if we're working with Parkinson's disease and we're going to increase the amplitude, we want to have that big body movement. That's one way we can improve quality of voice. It works across the board with other diagnoses. It doesn't have to be a neurological issue for us to need increased amplitude for it to send a signal to the brain that we need more effort. So I use that as a biofeedback mechanism, and just the body, it's all ramped up to make these big movements. So yes, so froggy jumps, those are ones that I do with kids a lot. And then, even just having, this is one as an adult, if you're listening, you'll want to watch in the mirror, stabilize your jaw, and then just tracing across the upper lip to see if you can do it. That was good. See if you can do it without, but that one.
That wasn't as good. I'm moving my jaw all
your jaw was really involved in that one. So that is where, so you want to
okay.
kind of stabilize your chin.
Yeah.
And then it's not moving. Better.
It's harder.
Better.
Yeah.
So
Nice.
you
Okay.
feel that tension?
Yeah, you felt the tension. Yeah, I got it. Yeah.
So did you feel more tension on your right side?
I think so. Yeah, I think I did.
So so that's where, and what we'll see is, again, it's like it's okay until it's not.
Yeah.
So this is where so I'll work with individuals on strengthening whichever side is not dominant, because if we have a dominant side, you'll see, well, we all do for the most part, but you can have just this, it's not even, and that translation can be faster with the jaw on one side versus the other. And that can cause its own disruption and problems. And again, as we have sarcopenia and other things start to set in, we're okay until we're not. And so then this is where people don't understand why they're having issues. And this is where we need to be more mindful of activating the swallow. And it's so much easier to train this before you're hospitalized with an issue. So this is why I want everyone to be doing these things so they're stronger and more coordinated now.
Yeah. Well, one thing you mentioned also was the cranial bones and like the fascia between them. How are you usually working on that? Like, this is like, I know there's cranial sacral therapy. Is that what you'd say you would be doing with patients, or what is it? What do you do?
So I am actually trained in cranial sacral fascia therapy, which is called the Gillespie approach. It's like a cousin to cranial sacral therapy. And I actually do utilize that as a part of my therapy, because for one thing, it tells me a little bit more about the cranial system. Like, are they open at all? And so what we assess for is going to be, do they have a rhythm, an expansion and contraction, or are they just completely locked? I see often, not always, but often, let's say someone's had a midline retainer or something that is in their mouth, and they're coming in because they suddenly, like I said, have hit a wall. And I'll feel, since they've had this device in or this appliance, that they have had this reduction in cranial movement. So that can be a real issue. So let's say, and I don't want to offend anyone, but let's say they've done Invisalign and suddenly they're having these issues. It can be, we just, and I work with the provider and say, hey, can we put some slits in there? Because they're not getting enough cranial movement. We need it to bend and bow a little bit with their body, so they're not locked up so much. Or it can be, so yes, it's a lot of it is I'm feeling the tension patterns. I'm feeling, are they having any patterns? Or are they completely locked out? And that helps. It also helps me to understand their nervous system a little bit more, and the role that their swallow, that their movements are having in just their overall dura tension. And then of course, it's going to radiate through the spine. And like I said, the sacrum and pelvic floor. So it's all tied together. Right. Very, very important.
And it's probably a significant indicator for their autonomic nervous system balance too, I would imagine.
Yes, right? Absolutely. And what was it? Friday, I had a kiddo with Pandas flare that was pretty significant.
Sure.
And, he's just sort of screaming in the corner. But as I'm going through and getting him just gentle, because obviously his nervous system is pretty sensitive, just some gentle movement through that system, all of a sudden he's calming down. And I won't say he was calm, but he was able to connect with his mom again. He was able to be present. And I mean, a kiddo like that, in that moment, I'm like, we're not going to be doing tongue exercises. That's not what we need right now. We're going to connect and regulate and help us open up the diaphragm, vagus nerve input, get us to actually be present. Because this is what I see a lot with a lot of kids, is that they're like in orbit. They're not here. And I've got to bring them back.
Right. And so I guess the final piece would be the oral pharyngeal swallow piece, right? We talked about the nose and we talked about the teeth. I want to go back to braces in a minute too, because I have a couple car payments every month because of that at the moment. But let's talk about the swallow. And this is definitely a very important piece. I know you talked about sort of what the speech therapists are working on, sort of the oral pharyngeal aspect of things, whereas there's different aspects working on like speech therapists specifically, right? So, or like maybe you can delineate that a little bit.
Sure. So when it helps to know the markers of the swallow phases. So we have what we call the oral phase swallow, and that typically is indicated from the lips And we can say the pre-oral phase because even you bring it to your mouth. So it's going to be the lips to the angle of the mandible or the angle of the ramus. That just, if we're looking at a fluoro or a swallow study, that's going to be what we sort of consider that swallow. And you can have a range of, some people won't initiate their brainstem or pharyngeal swallow until it gets all the way to the vallecula, things like that. So you have a range of, like, it's a little delayed in the onset of it becoming a brainstem swallow. But this is the important indicator, is that you control through the cortex, through what you're doing, what you're thinking, the swallow until it gets to that angle. Or roughly there. Once it gets about there, the brainstem kicks in, and it's a brainstem response. So when we're working on a brainstem swallow issue, this is what we call dysphagia. And you can have oral phase dysphagia, pharyngeal phase dysphagia. So let's say in the case of a stroke, you might see, okay, they have dysarthria, so their speech is a little slurred, and so their oral phase is a little slurred. It's an oral phase
thing, right?
But that's going to be more of that muscle activation that we're seeing. It's not necessarily a brainstem impact, and so this part's a little messy. But once it gets to the brainstem activation, they're okay,
right?
And that's not for everyone. I'll just say that's a case where it can be, but then maybe they had an infarct that was, partially affecting the pons. You might see, okay, now it's a brainstem issue, and they've actually had,
they have ALS or something like that. That's all.
Exactly. And so that can be a degeneration that's occurring, MS, where even Lyme's, where you'll see the myelination's been affected. So that signaling can be a little imprecise, and it's like, whoa, sometimes it's there, sometimes it's not. So what should happen is that our tongue, so again, the tongue, even though it's in the oral phase, it's the driver for the power and the impact of the pharyngeal phase or the brainstem response. So tongue should go, it should really be the strong muscle that pulls the hyoid and is getting this swallow mechanism going. When we yank the hyoid forward and up, that's hyolaryngeal excursion. When we have that, it opens really the pathway for us to be able to swallow the bolus or whatever it is. And it should help with that epiglottic inversion and everything covering. If we don't have adequate hyolaryngeal excursion, or so what that is the hyoid, it goes up and forward. If any aspect of that is limited, that's where you're going to have, maybe they swallow okay-ish, but they're getting a little bit of residue. So after the swallow, there's some stuff left, and then their airway's left open. So it's a little dangerous. Sorry, I'm getting in the weeds here. I love talking about the swallow.
No, this is good. This is really important. I just think in my personal family history, there's a lot of people that will cough or clear their throat after they eat all the time. And I've always wondered if it was sort of it seemed like there's a genetic piece, because it seems to be like run in certain men in my family, including me actually, but certain foods and certain lifestyle factors will certainly affect it. And you can see it being worse under certain circumstances, for example. So I find this whole thing very interesting.
So do they have a glottal fry? So is their voice affected at all?
No, I mean, not that I'm aware of, at least. They'll have, when they have to clear their throat, their voice will be affected to some degree, like before they need to clear their throat, that kind of thing. But not that I can tell, they don't have like a hoarse voice or anything like that, like on a regular basis.
So we do have genetic predispositions of things like the retinoids, which are going to be the little anchors for the vocal folds, that they can actually be different heights. And this is where you'll get a diplophonia, like the voice might sound a little different, a little airy, things like that, or where they're not quite getting that full closure of the glottis. So this can be, if we're having issues with hyaluronic acid, if we're not getting into deep stages of sleep, you have to have silence for that to actually be generated in the body and to go in and cover the vocal folds. If we're not getting that, you can start to have it where they're more exposed. They're not getting that smooth quality. And it does actually, we can get where they're not as thick as they used to be and robust. And that's where we start to get some of that messiness. And you no longer have that Valsalva that's as strong that should move everything through. And so you can have, again, some residue that's left.
Gotcha. So what are some things you usually recommend for that sort of initial phase, the non-brainstem phase that you work on with patients?
So that is going to be actually myofunctional therapy, like working on that stabilizing, getting the tongue to be in that appropriate place. If we have weakness, I'll be working on that. But in general, the tongue is pretty strong. So it's usually more of a coordination issue. I do have patients that have muscle issues. And so in those cases, more from a genetic standpoint, we are working on strengthening. And those cases, it's going to be against resistance. But for the most part, it's more of, okay, this is
it a barbell for your tongue that you have to kind of...
Yeah, actually. So, in the hospital, we'll use like a tongue depressor and we're pressing against it, things like that. And that can be a way to heighten it and help with that.
Nice.
But it really, I mean, it's a lot of just getting the specificity of the tongue movements and helping with that. So again, we're not wasting energy with the tongue being misplaced. If you have a better cupping of the tongue, or those grooves on the sides of the tongue are up, you're not going to have as much of this suddenly slushy swallow as if you actually all have it cohesively as a bolus in the midline.
Got it. So we need to be doing barbell strengthening of our tongue, is what it sounds like. I love it. Or tongue depressing, at least. Okay, I have one question on braces real quick. This is just a personal question and your thoughts on them. This has been a lot of fun. I really do appreciate all this info. This has been great. What's your take on braces? I mean, my sense is that if you're not changing some of the other dynamics, the braces may not work. That's what you were talking about with some of the appliances and things like that. Do you see this in kids as well?
Absolutely. So I see, and I do think it's important for us to talk a little bit about how it can even impact menstruation in girls. So we could see huge changes in things like this, and people aren't necessarily aware of it. So because the braces, it depends on what they're doing. So are we retracting? Is it because we suddenly have dental crowding? So when children get their teeth initially, they should have gaps between them. You should be able to slip a coin between each tooth and have easy space, because this is the body developing and making room for these adult teeth that are going to erupt eventually.
Right.
We have to be chewing to stimulate that eruption process. So if we're not chewing, we're not doing that. So all of that is connected. When we get braces, it's usually after the age of 7 or 8, and suddenly someone's like, oh, their teeth are crowded. They need this. So we want to be looking at, is it a dental crowding issue that it's because they're not losing those baby teeth and they have the adult and baby teeth all together, and so we actually need to exfoliate them? Or is it because the jaw has, and in both cases, the jaw hasn't developed sufficiently, which is what we're wanting. What I don't want is that we're pulling teeth. In kids, we can grow the cranium, we can grow the jaw. We do not want to be pulling adult teeth. So these are the adults that I see who've had 4, teeth removed, 5 teeth removed, whatever it is. And then they suddenly have all this pain. And
got it.
So braces are usually a Band-Aid, and they look good. I don't care as much about how a person's smile looks. I want them to have airway space.
Airway optimization. That's what you care about, right? Yes. So you're talking about, you can pull baby teeth, but you would never pull adult teeth, is what you're saying.
Right. And even if I wouldn't necessarily pull baby teeth, because I would want us usually, I mean, I'm kind of the queen at getting people to lose teeth. I'll be like, no, we're going to do this. And there's also, you can actually feel in the palate, we have fascia restrictions, like you'll just feel it's tight. And so sometimes it's just unwinding that a little bit. And
just by using your hands specifically.
Yes. So be careful. Don't do this at home. You might get bitten. But so it can be just doing that, and then using an amazing tool that I want everyone to get, the Myomunchie. It's called the Myomunchie. It's out of Australia, and it was designed by a chiropractor. And it's amazing stuff. Or it was designed by a dentist and then a chiropractor. She's now the one that's running it. But it's a great tool. So as adults, we can use the adult Myomunchie. However, you might have pain. So if you do, reach out, because there are different things that we don't have time to talk about. But it's a great tool. So getting kids to chew is usually what I want. Right now, I have a patient who he went through expansion and it, quote unquote, didn't take. And I was like, no, we are going to chew through this. And so I got him into the Myomunchie. He's been chewing and we've been working on it, and it has corrected his crossbite. So you can do a lot really before the age of 16. After the age of 16, it's a little bit more, because the sutures have set in anyways. They do expand and contract, but it's not as easy to move things. So what braces can do is they can pull back and they can tighten where I am wanting to grow and expand and get more movement. So do you know what your kids have braces for?
I don't have this information. I know one of my children had a lot of crowding. I think the crowding is a big piece, and and also had like a very smaller jaw overall. Had a hard time breastfeeding when she was younger initially too, and so had more crowding. So the idea I think is to open and widen her mouth
good.
and give her space.
Good. So does she have a rapid palatal expander in?
She did have an expander in. I think she still has one in now too. Okay. Yeah.
So it's now it's probably.
I had to like use a key and try to.
Yes.
Yeah.
Yes. So here's the thing.
Yeah.
When we do that, so this is where I like to know people's histories, because if you have that, and you're not chewing, what can happen is what we call a collapse. So usually it depends on the provider, but they might have you turn it for a month or 3 months, and then you hold it for 6 or 9, and that's to help it hold. You need to make sure she's chewing hard food, because you need those osteoblasts. You need to get it.
And she doesn't like to eat hard food because it's harder for her. Yeah,
it
this
is
good. Well, yeah, we could definitely take this online. I have a lot more questions for you about this, but this has been fantastic. Karindy, I'm going to say it wrong. It's Karindy, right?
Yeah, you said it perfect.
Okay. This has been fantastic, and I've learned like a huge amount. We do ask one question at the end of the podcast for everybody, and we've talked a lot about the mouth, obviously, but this could be about anything. It's the 3 ways that you think that anybody can live smarter, not harder. And again, it could be about the mouth. It could be about anything you'd like in your life. But what are the 3 things that you think that anybody can do to live smarter, not harder?
I actually think focusing on connection. This is a huge piece that I see and that I work with families on a lot, is just, I think we get so, we can, I love nerding out about all these things.
Yeah, no, I think we could go for like another couple hours. Easy.
Right. I think it's so important that we are actually making eye contact, connecting, laughing, being present. I think more than anything, because if you can breathe great and you're not aware of someone nearby or loving people, what does it matter?
Right. And it's like a chicken before the egg. It's going to help you breathe better too.
Exactly. Your nervous system's going to be more regulated. Lots of reasons why.
Nice.
I would say that's it.
Okay. Number 1 is connection. Do you have any others you'd like to share for 2 more?
So I want everyone to be mindful of putting your tongue tip to what we call the spot. So behind your 2 front teeth, there's it's like a little diamond. Put your tongue there. Okay. So this is going to be very important for regulation, for breathing. It's important for so many things, but just doing that can make a huge difference.
Love it.
I would actually say I want people, so we didn't talk about this at all, but I want actually people to put their hands behind their head. Okay. And this is one that you can actually do a little bit of an occiput release, especially since we're sitting at computers all the time. It's, and we're yanking our heads forward. I mean, just everything. If you just place your hands behind your head, and I can't fully show it because my headphones, but just that input to the occiput can help you regulate. And I teach families to do this at home. I'll be like, do this on your husband, do this on your wife, do this with your kids, just holding the back of the head as someone lays down. You don't have to do anything. So just with your hands like this, almost like you're
no pressure,
water.
Nothing, just like your own.
Just that. The fascia wants to release. It wants to unwind. It's a beautiful way to release tension through the cervical spine, to release that tension of the tongue pulling all the time. If somebody has tinnitus ringing in their ears, it's a beautiful way to soothe it. So I would recommend doing that. And then inviting your family to do it too, because I do think there's something important about that that connection of someone else, of their light receptors on your head. I think it's very important to have that. And I do, like I said, I want families to be touching their kids' heads and giving that soothing input.
That's beautiful. I love that. That's an easy one. So Karindy, where can people learn more about you and your amazing work and your podcast and everything else?
They can find me at Myohacker SLP on Instagram. My podcast is called the Myohacker Podcast. My website is myohackerslp.com. And I have courses for families because I do want to make this readily available to people. So I have a lot more that are coming out this year. So be ready for that. A provider course as well. So that's going to be pretty specific, but people can join the wait list and see if they're the right fit.
This has been amazing information. I learned so much. I was actually Really excited. I was really looking forward to this particular podcast because it's just an area that so many of us just don't know a lot about. And I'm so glad that you know as much as you do that, and you're providing all these resources, and you have your podcast, and I have a lot more questions for you offline about about other things.
Absolutely. I can't wait.
Yeah. Okay. Well, have a great rest of your day, Karindy, and I hope to see you soon sometime in person. Okay.
Yes, absolutely.
Okay. Enjoy the day. Thanks so much for tuning in to another episode of the Smarter Not Harder podcast, where we give you 1 cent solutions to $64,000 questions. And man, this podcast was awesome. I learned so much about the airway, the nose, the mouth, the palate, the tongue, the oropharyngeal airway itself, the soft tissues in the back, upper airway resistance syndrome, obstructive sleep apnea, the integration of the mouth with everything else in our body. I really hope you enjoyed this episode as much as I did. If you did, please don't forget to like and subscribe below so you never miss an episode. Check out Karindy's website, which is called myohackerslp.com. And we'll see you next time on the Smarter Not Harder podcast. Bye-bye.